Hi, good evening, everybody. Welcome to this session. I think this is going to the last session for this 45th comprehensive course on echocardiography. We're going to have interactive question answer sessions from all the delegates. I'm going to show you some slides and expect each and every one of you to identify those slides because that's important for the reason like whatever we have learned. And most important thing is this is despite the fact if we have not learned anything, we are going to learn more. With these few words, let me move on with this session of sequential analysis of acyanotic and cyanotic congenital heart disease. My first slide is going to be presented to Dr. Balram Jonathan Sharma. Dr. Balram, can you switch on your mic and tell me what the slides tells you?
Yes, sir. So
I'll put my arrow so that you can identify the structure. It'll be easy for you.
okay. Left atrium.
Just a second, start showing it. You see that the arrow is revolving for some time. Can you see this rounding, ongoing shadows?
I see the PowerPoint slide, the initial slide right now.
Yeah, first slides. And above the left atrium, what is the structure?
Left ventricle.
Other side?
Right ventricle, right
and
atrium.
Right atrium. So what do you see the abnormality in the static slide? You see the abnormality in this slide.
Sir, we cannot see your
It
slide.
looked.
Ghanshyam, if you can't see a slide, go out, join again, and click on Jorop Institute, Mrs. Reena Dua.
I can see also, sir.
May I request Dr. Ghanshyam to quit and then come back again?
It looked like.
Can't see slides, sir.
It looked like a VSD.
So wait for a few minutes. Let's see. It's getting hanged. It's got hanged. Okay. Okay. Can you see the presentation now?
No, sir.
So correct. Where is the VSD, Balram? Your answer is correct.
It seems near the
Okay, I'll point a arrow here.
a little lower.
Here.
A little lower.
Here.
Yeah, around there.
Why did you say this is a VSD?
Well, it's in the intraventricular septum, and you can see turbulent blood flow in that area.
Perfect. That is the scenario is if you, I'm sorry, something wrong is happening today. All right. This is the most important thing, Jonathan Balram, what you did it. You said that this is the turbulence. And why there's no turbulence? There's no turbulence out here. There's no turbulence out here. So this is a perfect reason why we say this is a VSD in a static slide, because whenever there's a hole, the blood will try to have an increased flow velocity across that particular hole. So Balram, perfect answer. I'll give you 4 out of 4. That's the first question goes to you. We'll come back again, Balram. We have a lot of time today. So
Thank
the
you.
next question goes to, I hope this is going to play. All right, this question goes to Dr. Vasudev Umakant Utpat. Vasudev,
Yes, sir. Good evening,
your
sir.
answer. Good evening, your answer.
This four-chamber view showing atrial septal defect with tricuspid regurgitation.
Why did you say this atrial septal defect is present?
Sir, right pulmonary vein flow is flowing from LA side to RA.
Mhm.
Flow towards the probe is showing as a red flow, and plus there is tricuspid regurgitation also with RA-RV
Okay.
dilatation.
Suppose this is an artifact. So how will you confirm, how will you say with confidence that this is definitely ASD?
ASD generally have RA-RV dilatation.
Correct. Is
And
it there over there?
yes, sir, is there.
So that is one the take home message is if you have an ASD, you have to have an RA and RV which is dilated. Because if you can't see an RV which is dilated, obviously there's something wrong and off or the slide or the hole is very small. So very
Yes.
simple. This is a tricuspid regurg. This is a pulmonic flow which is happening from LA to RA. And this is RV, this is RA, and this is LV, this is LA. And we have a dilated RV, RA. Correct?
Yes, sir.
So one more important thing. How do you say that this tricuspid regurg is significant or non-significant? That give you additional 1 mark.
Sir, if TR is severe, the flow from left to right is reduced, like it won't be there with RA pressures going severe. PA
TR
pressures.
is severe. You would like to improve your statement?
Tricuspid regurgitation with like PA pressures are increased, which is
Right.
indirect
Tricuspid
indicator of
regurgitation velocity is high.
velocity. Is high.
Then PA pressures are elevated, and then you have an underestimation of TRJ. Great, you get
Yes.
additional 1.5 5 out of 4.
Thank you, sir.
Great. So let's move on to Dr. Tushar Charkha. Tushar,
Yes, sir.
next
Good
slide
evening.
is for you. Get ready. I hope the slide goes on and on and on. You know, Devin, this computer does not like that we are talking about again, stop sharing and pause. All right, Dr. Tushar, here is the next question for you.
Yes.
Tell me what's wrong with this slide. Always try to make guess, you know, if you can't make it, at least think something is happening in this slide. First of all, what is this view is?
So this is Plaque's view.
Oh, okay. Then what is the structure?
Is aorta.
Okay. What is the structure?
This is LA.
What is the structure? Here,
LV.
here.
RV.
LV and RV on top of each other? And aorta over here. No.
Oh, this is short axis view. Sorry, sir. So this is short axis.
Good, good, good. So if it's sub short axis view, then what is this abnormality, man? You got 1 out of 4 at least.
This is V.
No intermittent talking. Please. He has to handle his own examination. Tomorrow he gets a case and he's not able to handle that case, then you're not going to be there to support him.
So can we play it again?
Okay, we'll do that. You're not going to take all 3 hours with you, man. You have to be faster. This is parallel short axis view at aorta. Chalo, I'll give you a hint.
So
Pass.
I cannot appreciate the turbulence, sir, so I'm not able to guess it. exactly.
Guess something. Fine. Guess something. There is no
VS
turbulence.
VSD.
No. Parallel short axis view at aorta and you're supposed to see VSD. VSD would be between 2 ventricles.
Yes,
Here is no 2 ventricles. You said what's 2 structure.
yes.
All right, let's move on to 1. I give it to you, Tushar. Dr. Tiam, are you there? Dr. Tiam Banikyu? He's not there. Ghansham, get ready.
Yes, sir.
So you have to identify what's the abnormality in this slide.
This one, sir.
Yes,
This is, sir, ASD.
great. Why you said it's ASD, Ghansham?
Because there is a turbo flow going from LA to RA.
Okay,
And even ASD is large because the turbo, the flow is much in larger amount.
yes, the flow is humongous. Almost there is virtually, there is no septal margin in this. Look,
Yes.
here's a margin. If you look carefully, the ASD margin is over here. There is no ASD margin over here. And
Yes,
look
sir.
at the dilated RA, dilated RV, and a pulmonic artery over here. So when you see a large ASD like this, you of course you don't find any turbulence, right?
Yes.
Great. So Dr. Ghansham, perfect answer, 4 out of 4. The next, get ready, Dr. Damodar alias Swapnil Arskar. Are you there, Damodar?
Yes, sir. Yes, sir. Good
All
evening.
right, the slide is for you.
Sir, this is the apical four-chamber view where we can see the agitated contrast saline
Infusion.
in the right side of the heart. So
Okay.
this is
What else?
This is
Very important, interesting topic in this slide is. Do you see any ASD or not? First of all?
so
Look,
the
you got already 2 out of 4.
so the contrast can be seen entering the left atrium.
Where?
Normally it should not, because it would get destroyed in the pulmonary circulation. But here, because of the ASD, the agitated saline is coming in the left atrium.
This is artifact. If you believe my word, this is all artifact. Whenever the contrast will come, where the contrast will go from LA to LV? It will
Correct.
go from
correct.
LA to
So there
LV?
is no contrast basically in this. So this
Correct.
is a normal. There's no ASD in this.
No. Look carefully. I'll give you a hint. Look at over here.
In systole, I could see some haziness in the.
That is
left
an artifact. Forget about that. There's one more thing apart from that. If you get 5 out of 4.
Is there for PFO?
No, PFO will always give you contrast shunt from right to left. Okay, I'll give you a hint. LA pressures are more than RA pressure, or RA pressures are more than LA pressures. What is your LA pressure?
LA pressure will be more than the RA pressure.
Correct. So if LA pressures are more than RA
More
pressure,
than the ASD
then
will not.
look it in this context.
So if the LA pressure will be more, then the ASD will not be seen. And in that case, the pulmonary artery pressure also will be high,
Pulmonary artery pressure will be negligible.
negligible.
The reverse. If the pulmonary artery pressure would be there, you'll be able to see ASD very easily, man.
Correct, correct, sir.
RV pressure, RA pressure would be more than LA pressures.
Correct, sir.
Okay, you want to take it further? I pass it to somebody else. There is one very important criteria seen in this.
Pardon me, sir.
There is an ASD in this. You got 4 out of 4, but you can have one more point.
A defect can be seen there, but basically this, since we are very parallel to the flow.
All right. So
This is-
we'll move on to Dr. Rahul Kenkan.
Thank you.
Rahul,
Yes, sir.
take this question. What additional thing you do see in this contrast?
Sir, the LV seems to be dilated.
LV is always be bigger than RV, man. I'm talking of a contrast. If you take this question, I'm not saying I'm not going to do anything. If you will give me a correct answer, you get 1 positive point. Or else I'm going to ask you the next question. No.
Yeah, anything regarding the tricuspid valve?
Dr. Ketki,
Sir, Vasudev, sir, is
Vasudev.
it the contrast getting cleared because of LA blood is getting in RA and that contrast area near the RA is getting
that is perfect. That is known as negative contrast, you know.
contrast?
Look at this patient. This is negative contrast over here. With every atrial contraction, you find a space out here, which is blackish in color.
Yes, sir.
Perfect. That is known as negative contrast.
So what does it signify?
It signifies that LA pressures are much more than RA pressures, and there is no shunt reversal from RA to LA.
Okay, sir.
Okay. So Dr. Vasudev got one more extra today. Great, man. And now Vasudev, you can buy one more point. Anybody can raise their hand. Anybody who can raise their hand, perfect, fastest, will get another one more point. How can we prove that ASD is present in this patient? This reversal of shunt is present in this patient. Please raise your hand if you can do that. Oh, great. Again, Rahul can raise the hand. Go ahead, Rahul. Unmute yourself, Rahul.
Can you hear me?
Yeah, go ahead, Rahul.
Sir, if the RARV is dilated,
No, I'm asking in this. Can you prove that ASD is present by doing anything?
transesophageal echo, sir.
No. I'm talking about transthoracic. Balram,
You can inject contrast into the left atrium.
no. How can you inject contrast to the left atrium, man? You're
It's
going to-
complicated.
No, complicated, but tell me, how do you get it? It's impossible. You cannot inject a contrast in the left atrium. Only one place where you can inject contrast directly in the left atrium is by when you have unroofed coronary sinus. Dr. Yogesh Patel.
By Valsalva?
Oh, perfect, Yogesh.
Sir, yes, sir.
You did the correct answer, man. Everybody agrees. Everybody agrees or not?
Yes.
What will happen if you do a Valsalva?
So the pressures in the holding phase of the Valsalva, right-sided pressures will be, a bit more than left-sided, and that will suggest a reversal of the contrast.
Very good answer, Dr. Yogesh. Your thought process was absolutely perfect, Yogesh. God bless you. You already get one extra before your turn comes.
Thank you, sir.
All right, Rahul, get ready now. Rahul, your question comes over here. What do you see over here?
So this is a parasternal short axis view with the aorta in the center.
Okay.
We can see the contrast. So
Yes.
can you like play this slide?
I'll play it again.
Not playing. Sir. Oh,
Just give me a second.
yes, sir.
It's getting older like me, you know. It's a very simple answer. Like there is a
Sir,
contrast
is this
in-
is this a PDA?
How do you say it's a PDA? This is the contrast which is filling across all the segments of RV, RA, RV, pulmonic artery, as well as the pulmonic artery bifurcations, correct?
Yes, sir.
And there is no contrast seen in aorta or LA. This is the clear spaces there. This is right pulmonic artery, this is left pulmonic artery,
Yes, sir.
correct? Now my question is, suppose this contrast is seen in descending aorta. What's the answer? I did a
So
contrast in
in-
right arm. It got, and then I put a probe in the descending aorta, and I got the contrast in descending aorta.
PDA.
Then
Yogesh said
it will
PDA.
be PDA.
Rahul, do you agree with him?
PDA. Sir.
PDA.
No, sir. Even yes, yes, sir. If it is
Don't
going
go
from
along with
the
them. You know, they always be
artery,
down. You know, they are
into
trying
the
to fool
descend-
you. Don't listen to them. I'll come back to Ranjit and Yogesh
sir, I
later
still
on. Just
think
give me some time.
It was
Yes
Dr.
or no?
It was Dr. Ghanshyam who answered, not me. I
Okay,
don't.
okay. Dr. Rahul,
sir, if the contrast is going from the pulmonary artery to the descending aorta, yes, sir, seems to be like a PDA.
why the PDA would be there?
So because first it will have to fill LA, LV, and then aorta if it is directly coming into the.
No. Man, PDA flow is patent ductus arteriosus. The flow is from DA to PA, descending aorta to pulmonic artery. What is the pulmonic artery pressure? I'll tell you. You'll forget about it. 25.
Yes, sir.
What is descending aorta pressure?
Sorry, the descending aorta.
Aorta is 120, as good as blood pressure
Acha,
is.
yes, sir.
So why the contrast will go from DA to this pulmonic artery to descending aorta? No, it will not go.
Sir, if there is Eisenmengerization,
What do you mean by Eisenmenger?
so reversal of shunt from
Reversal of
left-
shunt will happen. Why?
due to increased pulmonary vascular resistance.
Okay, this patient has got a blood pressure of 120. Not pulmonary vascular resistance, due to increased pulmonary pressures.
Increased pulmonary pressure. Yes.
This
sir.
patient has got a blood pressure of 120. What do you expect the blood pressure would be? 130, 110 or 100?
Also more than the more than 120, 130, sir. If there is a shunt reversal.
Sir, if there is VSD,
Suppose no, there's no Ghanshyam, there's no VSD. He is almost in a right line. So this is a case. He has answered almost the correct answer.
Yeah.
Rahul has done a good job. He said whenever we have a pulmonary artery pressure more than systolic pressure, in cases of ductus arteriosus, which is patent, there's a reversal of shunt is seen, and we see the shunt flow into the descending aorta.
Yes.
This was a classical case which was sent to us, which came to our lab with isolated like primary pulmonary artery hypertension. And by the time this boy reached to us, his vascular resistance was more than 4.5, and his pulmonary artery pressure was 130, 140 millimeters. This is unfortunate, but this is what we did. We did a contrast saline in the right arm, and we could see in descending aorta.
Yes.
Great, Rahul. Good job done. I hope you are able to understand my hemodynamics.
Yes, sir. Yes.
Right. Dr. Krishna Ansiram Yadav, get ready. Are you there, Krishna? Dr. Krishna, are you there? Mrs. Jigna Viresh? All right.
Sir, Jigna is not there.
Jigna is not there. Jayanti is there.
Yes, sir.
So you get ready, Jayanti.
Yes, sir.
All right. Next question. Oh, it's tougher for you. Jayanti, try.
There is a flow which I can see from pulmonary vein.
Is a very classical, very rare entity which we see in congenital heart disease. This is not ASD. I'll give you a little hint because I think I'm asking you too much from you.
Sir, is there flow between LV to RA?
LV to RA, right? Is a flow between LV to RA. Good attempt. Jim.
Garbade is just.
No, no Garbode syndrome. Is Garbode syndrome. Don't say Garbode syndrome. The Garbode is Mr. Garbode sitting upstairs will feel offended, you know. Great attempt. I must congratulate you, Jayanti. You did a wonderful job. This is classically a Garbode syndrome, where we have a VSD from flow from LV to RA. You see this blood flow which is happening? And if you hear these people, a very harsh systolic murmur is there, and the gradient is very high gradient because RA patient is only 5 or 10 millimeters. And this is very rare entity, usually not seen. This is a defect between atrioventricular space. I'll try to freeze.
And atrioventricular groove, VSD.
Yes. So I'm trying to freeze. Yeah. So this is where the mitral valve is attached. Here's the tricuspid valve is attached, and through which you find this atrioventricular defect. So left ventricle to right atrium. This is known as Garbode's syndrome. Very good attempt. Like it'll be good for everybody to learn. Like this kind of a things will really help you a lot. Great job done, Jayanti. Let's move on to Dr. Ranjit Shankar Mohite. Are you ready, Ranjit?
Yes, sir.
All right. Here comes for you, Ranjit. It's a very simple thing I'm asking. It's not rocket science I'm asking. Just look at this image very carefully and you get the answer. Attempt. Don't sit idle. Attempt at least. I know a little difficult, but it's a very easy thing, you know.
Sir, can you play it again?
I'll do that. I'll tell me how many times I'll play the same number of times. I hope like everybody must be enjoying this kind of a quiz, you know, like where you really enjoy these kind of things. And those people who are not there, they'll start missing it now. Come on, Ranjit.
No, sir. No, sir.
Okay. Dr. Yogesh, go ahead.
This is apical fourth chamber view. Looks like tricuspid wall is not at all moving and RA is torrentially dilated. Probably it is tricuspid atresia.
Wow, Yogesh. Where are you? Which city do you belong to, Yogesh?
Mumbai, sir. Mumbai.
Mumbai. And which hospital do you work, Yogesh?
I own my own hospital, sir. I don't.
You have some employment available at your hospital?
No, sir. No,
No?
it's not.
No way?
No.
Okay. You don't want to give an employment to me?
So sorry, am I wrong? I mean,
No, you're perfect. I'm not saying wrong. You're perfect.
Okay. Yes, sir. Yes.
Okay.
Sir.
Now
Thank you, sir.
you got a very good attempt. You know, this appears to be tricuspid atresia, right? I'll ask you one simple thing. Can't you see an RV in this patient?
Sir, actually, the LV is
Huge LV. This is LA.
and
Intraventricular septum is
just
bulging. RA is big. What is this
just
structure?
below, because that you can say hypotrophic RV it is. RV hasn't shortened because of
Hypoplastic RV.
Hypoplastic, yes, sir.
Okay.
Hypoplastic RV.
So
yes.
why do you see suppose there is no tricuspid, there is definitely tricuspid atresia is present. But why do you see this RV then? The two reasons for this RV. You get additional 1 point. I have already mentioned 2 points addition.
Okay.
Yogesh Namdev Patil.
Yes, sir. Yes, sir. Yeah.
You have made your
sir,
name
yes, sir.
today. Perfect.
Yeah, sir. For that,
how this RV would be present over there? Suppose you have a tricuspid atresia, so you will not be any RV. Even the RV will not be seen at all. So why
Yes,
this
sir.
RV seen? Attempt.
Yes. Because the pulmonary artery will be attached
No.
to right ventricle.
Pulmonary artery will attach to right ventricle. Blood will flow. Come back now.
No.
Valve, pulmonic valve will not let you to come back. Anybody else is interested can raise their hands.
There will be
Small VSD.
ESD.
Small VSD. Who said this first of all amongst you?
Ghanshyam.
Ghanshyam said. So
That should be
Ghanshyam got
there.
one answer. 1 plus Ghanshyam. Anything else apart from small VSD? That's a great attempt, Ghanshyam. One more reason why this RVC. Jai Singh, you want to say something?
So the PA is to
Shunt should be,
You please raise your hand. I'll call you with names. You know, my screen will immediately show your name. You get one, you lose one. Swapnil, go ahead.
So the one is that VSD and second is the pulmonary artery has to arise from the RV.
Pulmonary artery arises. No, pulmonary artery does not arise from R. It does arise from RV, but there is no reversal of flow. Because pulmonic has got a valve. I'll give you an answer. Let's not waste time on this. Even if we can't see a tricuspid valve, sometimes there's a flow across this tricuspid valve, which is not seen. Because what we are seeing in one dimensions only. Correct? So we are not seeing in 3
Yes,
dimensions.
sir, I'm saying the tricuspid.
Pardon? So that could be one reason like how this is happening. Anyway, it's done. Ranjit, you couldn't answer this question, right?
Yes, sir.
So it'll be remembered by you for a long time. Let's move on to Dr. Bhatkar Dalip Pandit. Are you ready, Dilip? Dilip is getting ready, I believe. He is not ready, he is getting ready at home. Dr. Dinesh Kumar Tiwari.
Yes, sir. Good evening, sir.
Good evening, Dinesh. The question comes for you right now over here in front of you. First of all, what is this view is?
So this is suprasternal view, sir.
Wow, great.
And sir, looks more like view of coarctation of aorta, sir.
That's great. You got already 4 out of 4, Dinesh. Now I'm going to ask you a couple of questions. The more you reply, the more you get. Maybe like 6 out of 4, 7 out of 4, 5 out of 4. My first question is, you said it's a descending aorta, but I'm seeing 2 descending aorta over here, one over here, one over here. This is coarctation of aorta, no doubt about it.
Okay.
So there are 2 coarctation of aorta. Aorta is bifurcated, is going down, one to lower limb, one to other limb. So why there's 2 coarctation of aorta? 2 images are seen out here.
So this is due to preductal involvement of.
Have you ever seen in your life 2 aortas?
No, sir.
Then look at this image very carefully, man. You have already scored 4 out of 4. Just give me one answer why I'm seeing 2 images. Yes or no? You can, you cannot. Rahul, go ahead.
Sir, is this aortic dissection with a false lumen?
You are going to lose. Don't say these words.
Okay.
Ankan Patel.
No, sir, I am, sir. By mistake, Rus.
Okay. Swapnil Damodar. Swapnil, you raise your hand.
So is there transposition of great arteries in this?
Transposition of great arteries will be seen over here.
No, so if 2 aortas are
2
there.
aortas, then 2 arteries in descending in long axis view? No. That will be seen in parallel short axis view.
Cortex.
This is not PDA. No, this is not PDA. Dr. Nida Khan.
Yes, sir. Is it collateral?
Oh, this is artifact, you know, like a mirror image when they sit together with each other, they are artifacts. The aorta will never divide like this. No, nothing PDA, nothing. This is the PDA and this is an artifact which seems like a mirror image. It's a very common phenomena which is seen when we look at a coarctation of aorta. Dinesh, you did a good job, but this is an artifact which all of you should remember. Everybody said descending dissection. Dissection is not possible. 1. 2. PDA would be seen on this side, not on this side. This is descending aorta. Here is a pulmonic artery, so PDA would be here. So remember, if you happen to see this kind of images, and how do you differentiate anybody? Anybody can open the mic and differentiate.
Stop the flow.
Stop
Color
the flow.
Stop the color flow, and the image will be seen. I mean, the B mode will show it is a single domain.
With color on.
So by putting a CW.
Putting a PW, not CW. If you put a
PW,
PW over
yes,
here,
sir.
you will find a Doppler spectrum pattern. If you
Yes,
put a PW over here, you will find what?
Will not.
You will not find anything.
Nothing, sir. Yes.
Right. Good, Kinkan. All right. Good question and good response. Dr. Pawar, are you there? Dr. Bhimrao Pawar. These people are really going to miss a lot of things today. Dr. Rakshit Bhardwaj. Rakshit. No. Ankan Patel.
Yes, sir.
Ankan, get ready.
Sir.
Look at this image very, very carefully.
Sir. Sir.
Sir is over, man. Now his legs. Tell me what's abnormality in this image.
Sir, this is sir, there is a flow between the aorta and the right ventricle, sir. So
No flow between aorta and right ventricle. It's a very simple thing which is seen over here, and if you happen to see very carefully, you get a beautiful answer for this. And previous images, I've shown you one of those previous images of the same patient. You can take it, you can refuse it.
sir, VSD, sir.
Yes, there's no VSC.
No, sir.
No, sir. So Ankan Patel could not answer this question. So anybody else would like to answer this question? Raise your hands. Two participants. Yogesh Patel?
Can you please?
Left ventricle and right atrium, sir.
Sirisha?
Left ventricle to right atrium, sir. Flow between left ventricle and right atrium.
There is no flow between left ventricle to right atrium. Where is the right ventricle, left ventricle to right atrium? Where is the right atrium seen over here?
Not
This-
seen, sir.
This is RV.
Sir,
The
Yes,
flow
sir.
has to
RV
be
is
LV.
sir, RV
RV
is
is
dilated,
dilated,
and that is
correct.
tricuspid regurgitation that is seen probably due to adjustment or something like that.
Tricuspid regurgitation is seen. What
that-
more very specific thing is seen in this patient? RV is dilated one. One second thing is very important thing is seen. Look at the septum. Focus at the septum.
Yes, sir. Paradoxical movement,
Correct.
contraction. Yes, sir.
That's the great answer. Paradoxical motion. Who's this guy? Who's
Yogesh, sir.
Yogesh? Yogesh. I'm going to come to Mumbai, Yogesh, one day. Definitely.
Yes, sir.
So you see a paradoxical motion, Yogesh. You see a right ventricle dilated. Then what do you expect in this patient?
Probably raised right-sided pressures.
Correct.
Right side, probably the tricuspid jet is also seen due to skewed views. Probably this must be severe pulmonary hypertension that must be there. And
Great. That's more than enough. Now correlate this with this picture.
this patient.
This is a patient.
So-
There we see a flow in the
Ice and
abdominal aorta.
mangarization. Yes, sir.
Yes,
sir.
this was
Yes, and,
reversal of PDA.
okay. Yes, sir. Yes.
And this is the image which told us about reversal of PDA.
Okay. Okay, sir. Okay, sir.
Great, good job done. So, Ankan,
Yes, sir.
no answer. Try next time.
Sir.
Nitin Gupta, are you there? Nitin? Getting ready. All right. Hiru, are you there?
Good evening, sir.
Back to Dhaka?
Yes, sir.
All great. So, Hiru, this question is for you now. Tell me one single answer. Don't tell me 10 answers. Very simple. You are lucky to get a very simple slide.
So this is the apical 5-chamber view showing LV is dilated, and there is a ventricular septal defect with bidirectional shunt.
Anything else, Hiru?
So can you again start the video clip?
Okay, I'll do that. We taught you about VSDs, type of VSD, which kind of VSD it is. You got 3 out of 4 already.
Sir, most likely, sir, this is a perimembranous VSD with outlet extension.
I don't say it's a perimembranous because unless until seen Palax window, I'm not going to say that. The AV group is right over here. So this is outlet, possibly muscular VSD.
Okay, sir.
Outlet, lower muscular VSD. Outlet, why? Because aorta is open.
Yeah, yes,
Correct?
sir.
Great.
Yes, sir.
So whenever you talk, you should talk of outlet, inlet, paramembranous, then doubly committed or muscular. All right.
Yes, sir.
Sirisha, are you there?
Sir, it can be doubly committed VSD.
No, it cannot be doubly committed VSD because doubly committed VSD is always associated with aortic regurgitation. And we couldn't see any aortic regurgitation in this patient. Right. Sirisha, are you ready?
Yes, sir.
Here the question comes for you. Nobody is going to help Sirisha this time.
Sir, parasternal short axis view at the level of aorta, sir, there is
There is a bread, there is a butter, this is a
there is
there is a vada, there is sambar, there is a idli.
sir, no,
What
sir.
is there?
Turbulence more near the right pulmonary artery, sir.
Okay.
Then,
In that turbulence, that is like right pulmonary artery is playing holy.
sir, is it ductus patent ductus arteriosus?
Come out. This is ductus patent arteriosus. What's problem in it?
Yes.
Great. Look,
Okay.
here's aorta. This is LA. This is RA. This is RV.
Yes.
This is pulmonic valve. The pulmonic artery bifurcates into right and left, and this is descending aorta. The large flow from DA to PA.
Yes, sir.
Right?
Yes, sir.
So what's wrong? What's going to take so much of a time?
No, I told that, sir, but I wanted to go in a sequential manner. That's
Oh, great. Then you have become intelligent than me. You know?
okay, sir.
Great, Sirisha, good attempt done. This is what, if the PADA is present, one more point for you. If this kind of a PDA is seen at the age of 5 years, what you will do with this PDA?
Then we have to correct that, sir. Surgical correction.
No, we do not do surgical correction anyway. Like if any PDA which is patent for a long time, Yogesh, you have raised the answer.
PDA
But-
device. Right,
Yeah,
PDA device.
we close the PDA with a device. Any PDA we do not leave at all.
Yes, sir.
Very simple formula.
Okay, sir.
In PDA, we always try to close them. And this is ductal, which is fetal PDA, huge among us. You look at the amount of flow which is happening. The
Yes.
principle is any PDA, don't leave it. VSD, hold on till 10 years of age. And majority of those muscular VSD will will close by the time the baby grows to 10 years of age. Paramembranous VSD are very difficult to close. They don't get closed. They need surgical closures. Muscular VSD, majority of them close.
So what is the best time to close the PDL? At what age should we advise?
Within 2 years of time.
Okay,
Because
sir.
PDA is the one which never gets closed automatically.
Yes, sir.
We normally don't leave them at all. Right?
Yes, sir. Yes.
So she did a very good job. Sirisha, excellent.
Thank you.
Went very scientifically. So Dr. Ganesh Tukaram Thomre. Ganesh, are you there? Dr. Sayali Nandram Baldre. Dr. Nand Kumar. Dr. Suman Kumar K. Dr. Suman, are you there? Dr. Ishwar Agarwal? No. Dr. Anupa George?
Yes, sir.
Yeah, she is there. So Anupa, get ready.
Okay, sir.
So what's the answer? Very simple. Oh, you are very lucky, Anupa.
Okay.
She says, why I'm lucky? She's thinking, why I'm lucky. Sir is giving me a tough question and then asking me why I'm lucky.
Sir, can you play one more time?
Sure.
Sir, it is VSD.
Done. It's VSD. Good. Good, good, good. What kind of a VSD this is?
Paramembranous.
Oh,
Uh,
you see
Single
paramembranous VSD in this view? Don't disappoint me. You know, like
it's muscular type, sir.
good, good is a muscular VSD. What kind of a muscular VSD now? Further. Inlet, outlet. Mid muscular,
sir,
apical muscular, lower muscular.
Inlet,
Why inlet? Why not outlet?
sir. Iota is not seen.
Great. That's a good point. So one is VSD, second is inlet VSD. What kind of a septum it is? Mid, apical or basal?
It's mid.
Mid-vascular inlet VSD. That's all.
Yes, sir. Okay, sir.
So this is almost a mid-muscular inlet VSD.
Yes, sir.
LA, LV, RV, RA, there is no aorta seen over here, and we are looking at the septum. This is the basal septum, this is the apical septum. We are able to see the shunt in mid-side.
Yes, sir.
So it's a very simple thing. Mid-muscular VSD. Good. You did a good job.
Okay, sir.
So next person, Amit Potulwar. Amit, ready? Amit, are you there? No. Dr. Umesh Rajur.
Yes, sir.
Get ready, Umesh.
Yes, sir.
Here's the question for you. Little tough.
Tough, sir. Tetology of ferret.
I said tough, not tough. It's a little tough question. I'm sorry, like it came into your hands.
VSD is there, sir.
VSD is there. Good, very good. I really appreciate your time. This is a VSD seen out here. This is a VSD. So these are two ventricles. I appreciate. I'll help you out in this. Then you can see what is these two.
Both RA and LA.
No, they are not RA, LA. Make attempt. You are able to do a good job. I'm not going to ask you a next question. I'll not give you any marks for this, Raju, but anybody would like to attempt? Raise your hands.
Is it bidirectional, sir?
What, ASD, VSD bidirection? No,
Yes, sir.
apart from that, no, I'm not asking for bidirection. I'll give you an Dr. Yogesh, can you will try?
So is it a transposition of
This is
great
transposition of
vessels?
great vessels. Great.
Vessels. Yes, sir.
Look, the one vessel is arising from here, the second vessel is arising from here,
From here, yes, sir.
and they are in reverse direction. So this is LV, this is RV. So this vessel is aorta, this vessel is pulmonic artery.
Okay,
And the
sir.
answer we get is look at their bifurcations. So good attempt, Yogesh. And I'll come back to you. You're really good. I must appreciate you, Yogesh, for your attempts. So Raju, I'm going to give you a next question. Any one of you can, whenever we look at the origin of these two vessels, when we angulate from parasternal short testis view at aorta, what we get this kind of image. We see two parallel vessels with each other, and they're arising at the same time from both ventricles. And when they're arising at the same time from the both ventricles, they put you an image like this, and this is the ventricule-septal defect. So in natural science, we do not see those two vessels arising at the same time from the cell, because left ventricle, right ventricle, aorta and pulmonic artery, they crisscross each other. Okay. Good attempt, Yogesh. Raju, are you ready for
Yes.
next question? I'll pass on
Yes.
this question to you.
Okay, sir.
Now, very simple. You are lucky now. Read before it gets stopped.
VSD, sir.
VSD is there. What kind of a VSD, Raju? I just said type of VSD. How do you classify VSD?
Muscular type.
Okay,
Apical.
muscular is apical. This is not apical VSD.
Mid.
No, it's not a mid VSD. This is lower VSD. Lower muscular VSD. Here is LV, here is LA, here is RA, here is RV. This is a lower muscular VSD. I appreciate. What kind of a lower muscular VSD it is? You're closer to answer, faster. I've got many questions, like really, today I've created a huge quiz. Now we're a little bit faster. It's almost 1 hour we have passed. Yes, we have passed almost 1 hour. This is outlet muscular VSD.
Okay.
Aorta seen? Can you see aorta where?
Yes, sir. Yes, sir.
So this is outlet muscular VSD. Why are you hesitating, Raju?
Yes. Yes.
Safila, are you there? Safila Vishal Sardesai?
Yes, sir. Yes, sir.
Okay, get ready. Answer, Safila, quick. We'll pick up a speed now.
So-
Mr. Modi has started his Vande Bharat.
Parasternal long axis view with ventricular septal defect.
Right.
Looks like overriding of the aorta.
Why the aorta is overriding? Where the aorta will override? This is not the
There is
place to write override the aorta.
There
This
a
is
VSD.
parasternal long axis view. This is VSD. What kind of a VSD in parasternal long axis view?
Perimembranous VSD.
Perimembranous VSD. So what is specific in this VSD? Just look very carefully. There's no
Bidirectional flow.
perfect. Why do you say it's bidirectional?
There is flow from LV to RV as well as the opposite side. There is
Answer
and green
is this is
red.
where the transducer is. Normally the flow would
Towards
from
the
LV
away.
to RV. Correct? So we
Yes.
see red color. When we see a blue color, it means the flow is
Color
from RV to LV.
LV.
So this is a paramembranous VSD. Some people call it paramembranous outlet VSD, and this is bidirectional flow.
Yes. Sir.
If this is the bidirectional flow, what do we mean by bidirectional flow in hemodynamics?
That means that the RV pressure is more than the LV pressure.
Bidirectional flow is
Or
it
almost
means equal, not more. It's equal.
more. Equal. Yes, sir.
So if my
There is
blood
ice-
pressure by our right arm is 110, it means RV pressure is also close to 110 millimeters.
Yes, yes, sir.
And this is not a good sign.
There
Last
is
point
ISD.
you can buy from this is, do you call this VSD as restrictive VSD or non-restrictive VSD?
Non-restrictive use.
Non-VSD. Why do you say non-restrictive VSD?
Because the pressure has already, there is no turbulence, there is no much turbulence. So, and the pressures have already equalized between
Equalized.
the RV and the LV.
Yes. When there's a large pressure gradient between two VSD, that is known as restrictive VSD. When there's hardly any pressure gradient and VSD is larger enough, we call them as non-restrictive VSDs.
Yes.
Well, last you can buy one more point, already got 5 out of 4. So what you will do with this VSD now?
You cannot close it, sir, at this point since it's already Eisenmengerized.
Right. If you try to close it, by which method of closure? Intervention or surgery?
Intervention is not possible, sir. Maybe surgical, but it would not be useful. for the
It will not
patient.
be helpful for this patient. Some people, they try to close by a device closer if they are 5 millimeters away from the aortic valve. Okay.
Yes, sir.
So that's how they look at this closure of this VSD. This is Eisenmenger syndrome classically, where RV pressure is almost equalized to LV pressure. This large VSD perimembranous, and the pressure equalization has happened. In this slide, we are able to see bidirectional flow. You got almost 6 out of 5.
Thank you, sir.
Sir, if we are not closing this VSD, then he will live lifelong with VSD.
I'm sorry, say it again.
If we are not closing this VSD, then how he will live?
Look, it's a very, I think it's a difficult question. Safina, can you stop your mic? Rest of the people, please stop their mic because the voice is ricocheting. The question lies from a fact that if you close them, they are not going to improve symptomatically. The answer is a very difficult answer to say. I believe like these people will not be benefited significantly as far as their symptoms are concerned with the closure of this VSD. Better answer would be if you look at the pulmonary vascular resistance, if they're not high, close them up. If they're high, then whether to do a closure, you don't do a closure, you're not going to benefit anything in this substance. It's a very well ambiguous question is, we have to close this defects before the pulmonary vascular goes up. And whenever you have pulmonary hypertension, the pulmonary vascular resistance is majority of time high. I'm not saying always, but majority of time. And we can calculate our PVR, pulmonary vascular resistance, by echocardiography as on today. Okay. All right, Dr. Mitul Jain. Mitul, are you there? Dr. Namdev Limbaji Chaure. Dr. Suman Chatterjee. Dr. Anchala Singh. Rahul Gore. Dr. Rahul, are you there? Shashank Prabhu Desai. Jai Singh.
Yes,
Jai
sir.
Singh.
Yes,
I saw Jai Singh. Jai Singh, ready, get ready.
Right, sir.
Little tough, Jai Singh. You just identify the findings in this image.
RV is dilated, looks
Right.
like
Right.
ASD also looking.
You can see a membrane, intraseptal membrane over it. Very carefully. You can see membrane is there. There is no ASD.
And contrast in both sides, sir.
There is no contrast. This is image which is a overdone 2D gains.
Okay.
Very specific finding in this patient as far as valves and other things are concerned.
Tricuspid valve is apically placed.
When normal, there's nothing more, something more in these valves. Look at the thickness of these valves. Do they look normal? Both the valves. And look at this this subject over here. I'll go back and play again. Look the accessory band. He's so thick and calcified.
Yes, sir.
Yogesh.
Sir, is it like congenital storage disorders or any leukopolysaccharide like
Correct. This is like where like I can compare it by amyloidosis. When everything is so thickened, look at the valves, look at the walls, look at the chordae tendineus, look at the accessory bundle. And this finally came out to be a storage disease in a newborn. Like, we don't expect rheumatic fever in rheumatic mitral valve, rheumatic tricuspid valve. Then we do not have rheumatism of accessory bundles. So this is what image which we picked up in the newborn. Look at the heart rate is almost 31, 38. Good attempt,
Yes, sir.
Yogesh. I'll give you one more question, Jesse. I know it was difficult.
Okay.
Now, very simple, Jesse. You can do it. Nobody is going to talk in between. Jesse, try. This is basic science, Jesse.
Yes, sir. RA is dilated
RA is dilated, okay.
and LV is too much trabeculated.
LV is too much tuberculated.
LA is also dilated, sir.
LA is also dilated. You are playing a good hockey, man, but you have to win the match.
And mitral valve is more apically placed rather than tricuspid valve.
Okay. Good job done.
Yes.
Number of goals scored. Good. Tell me the diagnosis, man.
Sir, this is actually a LA is attached to RV.
Wow. And
discordance of aorta, atria and ventricle.
Atrioventricular discordance.
Discordance, yes, sir.
Great. So I must appreciate your efforts. You did a perfect guessing. Get 4 out of 4. And you went so sequentially. Look, this is LA, this is RA, this is mitral valve. You said this is not mitral valve, this is apically placed. This is tricuspid valve.
Yes, sir.
Basally places mitral valve. So RA is attached to LV. It's a clean shaven structure, LV.
Yes.
This is heavily tuberculated. So this is RV. So LA is attached through tricuspid valve to RV.
Yes, sir.
This is a classical example for atrioventricular discordance.
Right, sir.
And why do you say this is LA? This is pulmonic veins are classically seen over here.
Yes, sir.
Okay. Good job done.
Okay. Thank you, sir.
So next is Dr. Shrikant Rajvilas Gote. Shrikant, are you there? All right. Vinay Sharma. Anudeep Reddy. Karanveer Thoughtward. Karanveer, are you there? Dr. Samrat Madanik. Samrat. Dr. Tamogna Das. Durgesh Makwana.
Yes, sir.
Oh, Durgesh, get ready now.
Yes, sir.
Tell me what is there in this patient.
LA is dilated, and
it is
there
dilated.
is there is a ASD defect connecting
ASD
the
defect.
flow from the LA to RA,
Okay.
and this is same thing like previous only. The RA opens into the LV, and the previous question, it looks same with an ASD additional defect. I don't know, I'm just
What
guessing.
was the previous question?
Transposition, discordance between the RA opens in the LV.
That is atrioventricular discordance with ASD.
Acha, with ASD. Okay, sir. Yeah, same means discordance with ASD.
Yes, atrioventricular discordance. Everybody fine? So look, this is LA, this is RA, this is large ASD flow. We could see a turbulence.
Yes.
This is tricuspid regurgitation. This is basally placed mitral valve.
Yes.
This is LV. And RV we couldn't see much, but this is a clean shaven structure. This is atrioventricular discordance with ASD.
ASD with ASD.
And when we have atrioventricular discordance, majority of time we have these associated defects. Correct?
Yes.
If we not have associated defect, what will happen? The two circuit will separately completely will be separate from each other.
Yeah. He won't be alive.
We will not be able to see any pictures.
Yes, sir.
Good job done, Durgesh.
Thank you.
Dr. Kevin Bora, are you there? Kevin? Ravi Bhushan? Ravi, are you there? Then Dr. Chandan Kumar Roy Mahapatra.
Yes, sir.
Okay, ready?
Sir.
Very simple, Chandan.
Sir.
Sir is always there, man. Tell me the diagnosis.
It is, sir, basically seeing the common atrium.
Common atrium, okay. Good common atrium.
There is no septum, and sir, also there will be common actually a common atrium with ventricular defect. So it is atrioventricular defect, epicushion defect, basically, I think, sir.
This is known as common AV canal defect.
Or common AV canal defect.
Yeah,
Yes, sir.
you are close by. There's no atrium. This is common atrium. Here is a ventricular septal defect, and there's one valve over here, second valve over here. This is morphological right ventricle. This is morphological left ventricle.
Left ventricle. Yes.
So
Sir.
this is known as common AV canal defect
AV canal
or
defect.
atrial, or we call them as endocardial cushion defect.
Yes, sir.
Good job. Let's get to Yogesh. I don't think Yogesh, you have to give you any. You got a Yogesh. This is a
Yes,
question
sir.
for you, man.
Okay.
Look, God is looking at you.
Sir.
You are able to reply every question. The God has given you the toughest question.
Arey. So it's a apical four-chamber view,
Perfect.
where now
Try.
the
You can
chamber,
try.
yes, sir.
Just think over
Yes, sir. Yes, sir. And the chamber seen on the left side is right atrium, and the valve is apically placed. Probably it is tricuspid valve.
Correct.
It is dilated.
Okay, correct.
In the left side, okay. And left it.
So
Left
neither Khan has
atrium.
raised her hand already. Try. You can do it. You
Left
can.
atrium.
Vasudev Utpat has also raised his hand.
So now I'm blocked.
No, don't get blocked.
And that,
What
yes.
is this structure?
Sir, can I guess, sir?
Wait a minute. What is this structure, Yogesh? Yogesh, are you there, or your connections are lost?
Sir, if
Yes, sir, I'm there.
me,
I'm there.
Okay, let's give it to Nida Khan.
Yes.
Nida,
Yes, sir. Yes.
go ahead.
So there is an additional chamber suggestive of quote atrium sinisterum.
Yes, perfect,
Yes,
Nida.
yes. Quote right.
Yes.
Yogesh, you could have taken it easily, man.
Yes,
Whenever
sir,
you see
quote right.
two mitral valve, there's a
No, I'll
costa
say
and
that, quote
triaster
right.
sinister. If
Quote
you
right. Yes, sir.
see two tricuspid valve, you always try quote triaster
Quote
dexter.
right. Dexter, yes, sir.
So this is one membrane which is dividing the left atrium into superior and inferior structures. Superior has got the pulmonic veins, inferior has got a mitral valve, and these two pulmonic veins they drain into superior structure because normally the images are upside down. So this membranes leads to raise of a PA pressure, and that's why RV they are dilated. So this is classical. Nida, good job done. You have taken care of a Yogesh because Yogesh was answering all the questions till now.
Yes, sir. Thank you.
Yogesh, you get 3 out of this, but already you have scored 1, 2, 3, 4, 5 numbers before.
Okay,
So you have got
thank you.
8
sir.
out of 4.
Thank you, sir.
So Nida, you got 1 more extra. Next question is for Majrul Islam. Majrul?
Yes, sir. Good evening, sir.
Good evening. Get ready. Ready?
Yes,
All
sir.
right. The question for you, Majrul. Oh, very simple, man. You are very lucky, Majrul. It's simple and difficult too. Go ahead, Majrul, fast.
Yes, sir. There is, sir, large VSD amounting to a single ventricle physiology, sir.
Okay. This VSD is what? Inlet, outlet, muscular, paramembranous. What VSD?
Mid muscular, sir.
Mid and basal muscular VSD. Large,
Yes.
mid and basal muscular.
Large.
Inlet, outlet, which one?
Inlet VSD, sir.
Inlet VSD. What do you say, inlet?
Yes. Aorta is not seen, sir.
Correct. Large muscular VSD occupying large muscular inlet VSD occupying basal and mid part of muscular septal defect. Correct?
Yes, sir.
And those two chambers are behaving like single chambers. What else apart from this?
Single. And
Look carefully.
valves,
Valves are okay, man.
sir, small atrial septal defect is also there, sir.
Great. Everybody look at this small atrial septal defect over here.
Yes, sir.
And this patient has already, RV has become bigger than LV. RA has become bigger than LA. So this was a catch for this patient.
Yes. RA is dilated.
RA is dilated. RA could be dilated because of raised pulmonary artery pressure, but that is how the catch was. RA is dilated and we could pick up this.
Yes, sir.
Correct? Good job done. 4 out of 4. Nida, ready?
Thank you, sir.
Yes, sir.
So Nida, the question comes for you now. Answer, Nida. Very simple, Nida.
Yes, sir. I'm just looking. So is 5-chamber short axis view where PDA can be seen.
5-chamber short axis view, PD can be seen. No.
Sorry, at aorta level.
This is at aorta level. This is parasite short axis view at aorta.
At aortic level.
Then
And
what
on
is it?
color from 1 minute, sir.
Yogesh
Pulmonary
has
artery stenosis second.
अब I don't know है या नहीं है तुम बताओ क्या है.
Sir, pulmonary artery stenosis.
Correct. This is the correct answer.
Yes, sir.
This is PS. Yogesh has raised his hand, you know, because
No.
Yogesh was right behind
Yes,
you. He was sitting and raising his hand, you know, like.
No, sir, that is.
So good job. Done.
Pulmonary.
This is classically,
Yes,
this
sir.
is aorta over here.
Yes.
This is RV outflow tract and his pulmonic artery, which shows turbulence out. This is classically valvular pulmonic artery stenosis. Correct? Great.
Yes, sir.
Good job done. Sai Prasad, are you there? Sai Prasad? Manu Kapil? Dr. Clay from Tanzania? All right. Balram, ready? Balram is gone possibly. Many people.
Yes, sir. Go ahead.
Okay, I'll go ahead, man. Go ahead. Sure. Balram, are you enjoying or not? Tell me simple things.
Having fun.
You're having fun? Okay. So next question is for you, Balram.
Oh my God.
Oh my God. I'm not asking you tough questions, man. I'm asking you very simple questions.
So looks like a short axis view at the aorta.
Okay.
It seems like there might be some flow between the LA and the RA.
Right. Good.
RA seems a little dilated.
Right.
I don't know. It's hard to tell if the flow. I'm not sure if the flow between the RA RV is appropriate or not. It seems like that maybe the valve isn't opening correctly.
The valve is opening. It's fine. This is what now you see in the frozen section. The hole is large.
Yeah.
And that's why you're not able to see any turbulence.
Okay.
And it looks like the blood is coming from, is going back, like it's giving you an artifact kind of image. And this was very difficult when we switch on the colors, but when we switch off colors, then we are able to see a good atrioceptal defect.
Okay.
So ASD can present in various forms. Now, what is the classification of ASD, Balram?
VSD or ASD?
ASD.
ASD, it kind of depends where it is and the size.
Now, what a variety of ASD will remember? What varieties of ASDs are there? Types of ASD?
I guess like the perimembranous.
That is VSD. That's not ASD.
I guess you could go by the location,
right.
Whether it's whether it's near the valve or what exactly type it is. If it's primum, secundum,
and
coronary sinus defect.
Right. So VSDs are of when at the level of fossa ovalis, this is known as secundum. When it's closer to atrioventricular valve, that is primary VSD. Septum, primum VSD. ASD, not primum VSD. ASD. Then at the level of sinus venosus, that is SVC or IVC type of ASD. Then last is unroofed coronary sinus.
Right.
So remember, and majority of ASD which you see over here, they are secundum ASDs.
Okay.
And whenever we have a primary ASD, the picture majority of time with primary ASD is like this. Okay.
All right. Thank you.
Good question. Good answer, Balram. So, Dr. Utpat, now is yours.
Yes, sir.
So, here is an image for you, Dr. Utpat. Look carefully. This is congenital heart disease. And now patient is carrying an iatrogenic disease.
It's a ASD device which is coming in.
This is ASD device. What's wrong with this ASD device?
It's abetting the mitral valve.
Is abetting the mitral valve. Is a little bigger ASD device. People who have not seen this image, look at the ASD device is almost getting closer to atrioventricular valve margins, and the device is so huge that its impact is getting into the atrioventricular valve. There's nothing wrong with this device, but this is an oversized device for an atrioceptal defect. I'll show you a couple of images subsequently for the images which are good size ASD device, not oversized ASD. Good answer. God bless you.
Yes,
Utpat. Then we have Dr. Tushar. Tushar,
Yes, sir.
you scored 1. Now you got a chance to score more. Ready?
Yes.
So this is same image, like there is no obstruction to the lab. All right. Tell me what is abnormal in this patient.
This is a 4-chamber apical view.
Right.
Tricuspid regurgitation and ASD.
Right. If it's a tricuspid regurgitation, ASD is present, why I'm showing this picture again and again? Look, very specific thing which is seen in this image. Go beyond than that. You've already scored about 2 out of 4.
Sorry.
Can you comment on RV function?
So RV is dilated, RA, RV both are dilated.
And their function?
So impaired systolic function looks like impaired systolic function.
RV function is reduced in this patient.
Yes, sir.
And look at this contraction of RV. Like this is not moving, thickening at all.
No contraction at all.
Yeah, this is like large ASD with severe pulmonary regurgitation, tricuspid regurgitation, RV RA dilated, and now the RV has started failing.
Yes, sir.
So that is the most important thing for this patient.
Yes, sir.
Good try. I'll give you 4 out of 4, but you did a good try this time.
Thank
God
you.
bless you. Next time. Now we have Dr. Ghanshyam Motisaria. Ghanshyam, are you ready?
Yes, sir.
Yes, Ghanshyam, what is this?
This is subcostal view.
Okay.
And we can see there is a ASD.
Right.
Left to right shunt.
Correct.
And RA-RV dilated.
Right. How did you say right to left shunt or left to right shunt? What did you say?
Left to right shunt.
Left to right shunt. Okay.
Yes.
You like to improve your picture? Improve your sentence, Ghanshyam? Quick, we are losing. We have got not many slides to go. You know, we have come only 50% of our slides. We have to be a little faster. Anybody who says very significant finding in this is not pure ASD.
Coronary root sinus.
No, this is not coronary root sinus. So first raise is I don't know what is name coming up with D. Umesh Raju. Umesh. Dr. Yogesh.
It looks like patent foramen ovale. I mean, it's an
It's a ASD, small ASD with the reversal of flow by. This is agitated contrast saline. He did not talk
Yes,
about
sir.
contrast saline, and you
Yes,
could
sir.
see some bubble coming into the.
yes, sir. Yes,
LA.
left atrium. Yes, sir.
But one more finding in this particular image, dilated RVRA. But one
Yes,
more
sir.
finding. Look very carefully. LV is hypertrophic.
Yes.
Yes, yes.
This patient had significant coarctation of aorta associated with it. And the cash point was thickened LV. All right. So next is Ghanshyam, fairly good answer. I'm not saying. Damodar, are you there? Swapnil?
Yes, sir. Yes, sir. Yes.
Now the question is for you, Swapnil. Little tough. I'm not saying it's not easy. It's little tough image. But
RA-RV is dilated.
right, they are dilated, no doubt about it. So Dr. Umesh Rajul has raised his hand, Yogesh Patil has raised his hand. Okay.
There should be a ASD there.
There should be an ASD. There is no ASD anyway. Hirul Amin and Ghansham is
Is it
also
a apical VSD?
apical VSD. Perfect. This is apical VSD. What more? There is a VSD out here. What more? Apical inlet VSD. What else?
Apical inlet VSD. In the
It's a
LV
very,
looks more
very rare
trabeculated.
picture. We hardly see this kind of a picture in our life. Once in a blue moon.
LV is looking more trabeculated than the RV.
LV is more looking more tuberculate. With large VSD, LV is more tuberculate. I'll take it. What else apart from this? Very simple one finding which is telling you. We don't get this kind of a picture. All right. Ghansham, you want to try? No. Hiru Alamin?
No, sir.
Hiru?
Sir, most likely this patient has a Western anomaly of the tricuspid valve
Good.
with
Very
an
good.
ASD.
This is Epstein anomaly of the tricuspid valve. There is a ASD. Somebody said, he said ASD, Damodar. I do agree. There's a ASD. I'm sorry, I said no, but there's a ASD out here, and there's utilization of right ventricle.
Right ventricle.
There's a large VSD. Anything else, Hiru? अरे भाई जो दिख रहा है वो बोल रहा है, जो बोल रहा है वो दिख रहा है, जो दिख रहा है वो तो बोल ही नहीं रहे आप. योगेश?
I am not able to see anything. But VSD to he has already said, so
Yes.
nothing
More than that.
more than that.
Dr. Umesh Rajur? Anybody can open up the mic and tell me what is it.
RV dysfunction है क्या?
आरवी को बच्चा कॉन्ट्रैक्ट कर रहा है.
कुछ दिख नहीं रहा है.
Mitral valve
Who is this guy?
is the single mitral valve.
Identify yourself. Who's speaking?
Dr. Swapnil, sir. Dr. Swapnil.
Swapnil. Swapnil, you are speaking about it, mitral valve. Where is mitral valve? There is no mitral valve.
There is no mitral valve. Correct.
So if there is no mitral valve, what is the diagnosis? I'll give you 5 out of 4 if you'll tell me the diagnosis. Otherwise, you get 4 out of 4. Chandan Kumar Rai Mahapatra, waiting. He's waiting. Okay.
No,
There is
sir.
mitral valve atresia, man.
Mitral valve atresia.
Where is the mitral valve? Can you see the mitral? Can you show me the mitral valve?
No, I thought that was a single leaflet, sir. Yeah.
There is no mitral valve over here.
Correct.
You people have said everything in this patient except mitral valve. So this is a very rare congenital heart disease. The child survives because the child has got a ASD, child has got a large VSD. So both the chambers are getting a supply from it, and we do not have any mitral valves in this. Mitral valve atresia. We saw tricuspid, we saw mitral, and this is somebody very correctly picked up. This is utilization of right ventricle. This is displacement of tricuspid valve from AV group to upper side. So it's a rare combination of ASD, VSD, Epstein anomaly along with mitral atresia. All right, good. So next person ready? Rahul?
Yes, sir.
We'll increase our speed now, Rahul. Quick answer, 1 minute answer, Rahul.
Sir, there is a common atrium. The interatrial septum is
Good,
not
common
seen.
atrium is there.
There is severe TR. So is this AV canal defect?
This is classically AV canal defect. Here the issue is this is little variant of AV canal defect. This is not truly an AV. This is not a single AV valve. Look at the tricuspid valve over here. Look at the mitral valve over here.
Yes, sir.
So here is a tricuspid valve, here is a mitral valve. This is no VSD out here. We really appreciate VSD. We have to be more careful. It could be,
Yes,
it could not be. But the valve is not a common AV canal defect. So this large atrial septal defect, there could be a VSD. This is a variant of common AV canal
Variant of,
defects.
yes, sir.
Okay, good. So we'll go a little faster, Rahul, now.
Yes, sir.
Next is Dr. Jayanti. Are you there? You left.
Yes, yes.
Jayanti?
Yes, sir.
So this is the same thing which I showed you a couple of minutes back. There's a VSD out here. And this is like 2 leaflets of mitral and 1 leaflet, 2 leaflets of tricuspid valve. Nothing to say. Next question, Jayanti. This is a question for you now.
Sir, the first thing is there is a tricuspid regurgitation. This site is RA.
Okay.
And this side LA is connected to RV.
Okay.
Atrioventricular discordance.
Atrioventricular discordance. Okay. Agreed. Now, if I put this slide along with this slide, please switch off your mic. Chandan, your mic is on.
Yes, sir.
All right. What exactly is happening in this patient? So you will still try?
Yes, sir.
Go ahead.
Sir, I'm not able to see the second slide actually.
Okay, I'll
First
show you
slide
this.
I'm able to see. This one, yes.
So this is RA, this is LV, and this goes into a vessel and which bifurcates. There's no bifurcation. No, there's no bifurcation of this vessel. This is, let me just complete it faster. This is I'm sorry, this is bifurcates. This is congenitally corrected transposition of great vessel along with atrioventricular discordance. So God has, despite LV, RA has gone to LV, and this LV has bifurcated. The aorta has so-called aorta, it has bifurcated into 2 vessels. So they're able to maintain their relationships. Tough, little bit tough. So we go to next, Ranjit Moite. Ranjit?
Yes, sir.
Improve your score now. This is a newborn, born with this illness. Very simple slide, Ranjit. Yes or no? Ranjit, quick. Anything you see abnormal in this patient?
LV is dilated.
Great. I got 1 number. Tell me more.
RV is very small in size.
RV small, chinky size. What else? A newborn born with this disease. This is from all my own labs. You know, I'm not borrowing from anywhere. Umesh Raju, you want to take it?
Sir, single ventricle.
Single ventricle. Wrong. Hero Alameen.
Sir, non-compaction of
Perfect.
LV.
This is non-compaction of LV. Look at the tuberculated LV, dilated LV, and poor LV systolic contraction. So good job done, Hero. This is a non-compaction of LV, which patients are present with this non-compaction of LV. So Ranjit, did you see this answer?
Yes, sir.
So that's important, you know, like you have to identify. you could see a dilated RV which is not contracting poorly, which is contracting poorly.
Yes, sir.
All right. So we go to next Ranjit. After Ranjit is the Bhatkar is not there. Dr. Dinesh Tiwari. Dinesh, are you there? Dinesh left. Dr. Bhimrao Pawar is not there. Ankan Patel, chance to
Yes.
earn some number now, this uncle.
Sir,
Okay, ready?
sir,
All right. Answer. There are
Sir.
3 pictures in this patient, and you have to give me good answer.
sir, the LV is dilated, sir, in the
Okay.
second picture. And sir, there is also one membrane in left ventricle, sir.
Okay,
And sir, one is the Doppler image, sir.
right.
And sir, I think so. There is a membrane in left ventricle, sir.
Okay.
And sir, mitral, and sir, there is also a membrane between left atrium and left ventricle, sir.
Left atrium, right ventricle. This is left atrium. This is left ventricle. Here is
Sir,
the
and sir,
membrane.
Sir,
What else? What is this picture? What is this picture?
sir, there is turbulent flow, sir.
In
Sir, in sir, pulmonary flow. No, sir. There is turbulent flow, sir. In
most pardon me, right?
sir,
Ankan, you have not read anything. Last time you are present or not present for last 3 classes?
yes, sir. I was there, sir. Only last class I was not
So
there,
why so, man? This is a very simple thing.
sir.
What is this right picture?
Sir, that is the sir outflow tract of the right ventricle, sir.
Okay, no, it's wrong. It's wrong. Dr. Ghansham,
Is this coarctation of aorta?
perfect is coarctation of aorta. Good. What else in coarctation of aorta? What's the gradient on left hand side? 43. So you want to comment along with all these 3 pictures, Ghansham. Improve your marks.
Pardon me, what you said?
If you put all these 3 pictures together, you want to say comment something? No.
I don't get.
Dr. Umesh Raju, I gave you 1 point, coarctation of aorta, Ghansham, extra.
Post-rectal coarctation of aorta.
Coarctation of aorta is there. What else? Put these 3 pictures together. Dr. Yogesh,
So the LV systolic function is not seen.
is poor. LV systolic
Poor,
function
yes,
is
function
poor.
is poor.
So what will reflect to these pictures? This function will reflect to what? The gradient across descending aorta would be underestimated.
Yes, sir.
It's
Yes,
not
sir.
43. The
Yes,
gradient
sir.
would be much more than that. That's what is
Yes,
trying to
sir.
tell you this picture is. Some people will say the gradients are not enough to open up this coarctation of aorta. But the gradient has to be high because my LV function is poor. So what we did when my colleague did not agree, we gave a dobutamine to this patient.
Yes,
We
sir.
increased his LV function and the gradient went to almost 100 millimeters of mercury. So when you put these pictures together, this is coarctation of aorta. And some people say, look, the gradients are not enough. I said, let's give a dobutamine, the gradient come out to be 100. Because of this coarctation of aorta, the LV function had got down. Coronaries were normal. And this is a necessary bundle, which looks like dividing the LV to RV because LV is dilated in this newborn. Okay. This is how the picture present. So Ankan, read. You need,
Great.
you have to spend time. Next question goes to Hiru Alamin. Hiru, good, get the answer. Hiru, are you there, Hiru?
Yes, sir.
Answer.
Sir, this is the parasternal short axis view at the level of the great vessels. There is a 10 o'clock position and VSD, most likely perimembranous VSD.
Perfect. This is perimembranous VSD. This is parasternal short axis view at aorta. This is very poor picture, but you still could identify it. So here is RV. Here is the three parts: proximal, middle, and distal. Proximal will show paramembranous VSD, middle will show muscular VSD, and the distal will show doubly committed VSD. Good job done. I think I was little hesitant in saying that let's move on to next slide, but you picked up well. That's how the paramembranous VSD looks like in short axis view. Sirisha, are you ready? Sirisha? Sirisha, are you there? You have left. She has left already. So Anupa George.
Yes, sir.
Okay, Anupa, next question is for you. Tell me, Anupa, what do you see in this picture? Quick.
Sir, you can see
What is this view is? First of all, tell me this.
flax view.
Flax view. So what do you see in this flax view? Mitral valve, normal, abnormal.
Mitral valve normal, sir.
Interventricular septum, normal, abnormal.
What is hypertrophy?
Hypertrophy. Okay. Then what do you see in aortic valve?
Aortic valve calcification.
Newborn. Don't tell me this.
Okay.
Very specific finding, Anupa. If you just pinpoint a finding, they'll be done.
Aortic root dilatation.
Aortic root dilatation, done, taken. Okay, I'll pinpoint.
Bicuspid aortic valve.
What is this valve is?
Bicuspid.
How do you say bicuspid in this flax window? You can never say bicuspid aortic. You have two cusps. What is this cusp is? Right, left, or non?
Right.
Right coronary cusp. Normal, abnormal.
It's normal.
What is this cusp? Normal, abnormal. What?
Seems to be.
It is prolapsing back into the LA.
Yeah.
Prolapsing back into LVOT. But coaptation line is maintained. And this is non-coronary cusp.
Okay, okay,
so
sir.
there's a prolapse of non-coronary cusp is seen in this flax window.
Okay, sir.
Right?
Yes, sir.
If I
Yes.
switch on the colors, you'll find a severe, you'll find an aortic, I don't say severe, I'll say aortic regurgitation. Then you have to look at all three cusps of this patient. RV looks to be high, LV looks to be hypertrophic.
Yes,
So
sir.
this is the child which is born with this prolapse of non-coronary cusp of aortic valve.
Okay, sir.
Okay?
Okay, sir.
So that's how we go.
Okay, okay, sir.
All right, Anupa. I'll give you 3 out of 4, but you have to be really update yourself.
Okay, sir. Okay, sir.
And next is Dr. Umesh Raju. Question ready for you. Umesh?
Yes, sir.
Go ahead.
It's a apical core chamber view, sir.
Ghansham, can you switch off your mic? No, you have already switched off your mic. Anyway, there is a lot of noise coming out. लोग इडली खा रहे हैं यार इसके अंदर तो बैठ के. Just a minute. Let me just silence them up, or I'll shut them out completely. You know, if I find it out, I'll shut them out completely. This is not acceptable at all. They are shouting on these mics. Okay, go ahead, dear. Umesh,
Yes, sir.
go ahead.
Is it VSD, sir? Interventricular septal defect?
No, there is no interventricular septal defect. Little tough. I'm not saying that this is good for you. This is little tough. I do agree it's little tough.
Not getting, sir.
Okay. Umesh Raju could not get it. Anybody would like else to take it up this question?
Can I try? Yogesh?
Yogesh, go ahead.
Sir, it looks like is it a short axis view at the aorta, but aorta is not seen. I mean, probably, I mean, I don't know. Because this appears
This
to be
is
left
modified three-chamber view.
three-chamber view. Okay. Chamber view.
What is this valve? This is aortic valve.
Aortic
This is
valve.
mitral
Okay, sir.
valve. This is
Mitral valve.
LV.
Okay. So the
There's
LA is
something is seen
membrane.
over here.
Diet membrane in the atrium.
Membrane in the atrium is known as what? Cotritum sinister. And more apart from that, what is seen over here?
Clot.
ASD device. No clot, ASD device, man. So what happened? Somebody looked at the ASD, they forgot the cotritum sinister. So they corrected ASD and they left the membrane. This I picked up from international demonstrations. This is cotritum sinister with the ASD device in situ now. So large LA. Look at the picture, very atypical kind of a picture which is seen over there. It's not easy to pick it up, but
Yes,
this is
sir.
what it is. This is cotritum sinister with ASD device.
Yes, sir.
And what to do now is a very simple thing. What we do is like we'll take a catheter inside. As we do a balloon valvotomy, we'll open up this membrane. Now the problem comes how to open up this membrane. Because when we take a balloon from right side to left side, there's a device already sitting inside. Got my point? What I'm trying to tell you?
Yes, sir.
So for interventional cardiologists, this is a challenging task. So if somebody who is really dynamic, they have to take out a device. I don't know whether they can take it or not. And then do this balloon valvotomy of this membrane. Anyway, this is what is like sometimes we are left with when we're in a hurry and when we do a, what do you say, scanning echoes. This is scanning echo syndrome. Okay, let's take out next. Safela, are you there?
Yes, sir.
Okay, Safela, try next question. Very simple, Safela, one line answer. You have seen this question before.
Epstein's anomaly.
Epstein anomaly, great. Look, the septum is, this tricuspid septal leaflet is plastered to interventricular septum.
Yes, sir.
Can you see this? This is all tricuspid valve. Great job done, Safela. Appreciate.
Thank you, sir.
You have scored in 2 questions, you have scored 10 marks.
Thank you, sir.
8 out of 10. 10 out of 8.
Thank you, sir.
Great. Jai Singh, try next question. Are you there, Jai Singh? Jai Singh is tired, has left already. So Jai Singh is not there.
Sir, I am here, sir.
Okay,
Hello.
okay. Sorry, Jai Singh. So next question, Jai Singh, for you. Newborn. I'm trying to show you the best possible clips of my like collections. You know, I don't say like this is collection of my clips which I can show you. They are not a one day. They are almost 25-30 years of a collections. Little tough, Jesse. You can try still. What do you see in this patient, which is something normal or abnormal? वो दे दो, इसमें से डाल। Jessing, try.
Septal thick, sir.
There is septal thickness is present. Okay, done. I'll appreciate. More than that, septal thickness. What is there above LV? This is what view is this?
Modified Clark's view.
Okay, agreed. If it's a modified Clark's view, what is this? What is this? This is LV. This is RV. Correct?
Yes, sir.
And you can see multiple masses in RV. Here is the interventricular septum. Look at a clearly interventricular septum over here. You see multiple masses in RV. Which newborn condition is there when we see multiple masses in RV? Anybody can raise their hands. Is a spontaneously regressing condition. I'll give you a hint. Rhabdomyoma. This is a classical picture of rhabdomyoma, rhabdosarcoma. Myoma, rhabdomyoma. All right.
Okay, sir.
So you'll not forget this picture ever in your life.
Okay, sir. Thank you.
Then Durgesh Makwana, are you there, Durgesh?
Yes, sir.
All right. Next question is for you, Durgesh.
Yes.
What is seen in this picture, Durgesh?
I don't know. It's very tough for me at present.
Oh, it's tough for you, Durgesh.
Aortic arch. I don't know.
This is not tough. This is very simple, Durgesh. Ghanshyam has raised his hand already, Durgesh. You have got many
No,
friends
sir.
of yours.
Yes,
sitting
sir.
over here.
No, sir. I'm not able to make out this.
Okay, Ghanshyam, go ahead.
This is again coarctation of aorta.
Yeah, aorta is.
There is no coarctation of aorta. This is pure coact. This is normal descending view of aorta, where we can see all three vessels: left subclavian, left common carotid, and innominate over here. And maximum, if somebody can say, we can say that there is a turbulence present in descending aorta, but this is not there. This is how sometimes we see all three vessels of the arch of aorta and descending aorta. So this is left subclavian, this is left common carotid, and it is innominate.
Okay.
So this is normal picture of presentation.
Yes. Okay, sir.
All right. Next question goes to Dr. Chandan Kumar Roy Mahapatra. Chandan?
Yes, sir.
Answer. Quick one-line answer, Chandan. What is this view, first of all?
This is a suprasternal view.
No, this is not suprasternal view.
No, sorry, sir. Not suprasternal. It is a
And he mean to say support.
Sir, this is a epigastric view.
Okay, this is epigastric view. What do you see in this epigastric view?
Sir, IVC.
What is IVC? IVC good, bad, or beautiful?
Not dilated.
Gorgeous, gorgeous.
Gorgeous, yes.
Look, this IVC is huge dilated. And what's the importance of this? These are all hepatic veins which are seen over here.
Yes, sir. I got it, sir. All the hepatic vein are dilated and IVC also dilated.
Right. So if you happen to see this kind of hepatic vein which are dilated and IVC is dilated, then what is your possible diagnosis?
Sir, possible diagnosis of either there is a, sir, 2-3 things. Either, sir, is a sinus venosus HD of IVC type or any post-hepatic dilatation.
When these things are dilated, it means the RV-RA pressures, they are very high.
Very high.
That just implies that RV-RA pressure are very high. They don't say anything. They tell you RV-RA pressure are high. So you're not. You have to keep it updated, man. You're not doing good jobs.
Okay, sir. Thank you.
Okay, Ghanshyam, you want to say something?
Severe pH.
Yes, severe pH. You did the perfect answer, Ghanshyam. That's what exactly I was looking forward for one line answer, Ghanshyam. You know how much marks you got out of 4, 4, 8 and 11. 11 out of 8.
Thank you, sir.
Great job. This is severe pulmonary artery hypertension when your IVC is fully dilated and hepatic veins are seen. All right. So let's move to Yogesh. Yogesh, you always score good
Yes,
marks.
sir.
Next
Yes,
is for
sir.
you.
Yes, sir.
Go ahead, Yogesh. No, this
Yes, sir.
question
One
has been
second.
seen already. Let's leave it.
Yes, sir.
Here comes Yogesh. Oh, it's again tough for you. The God is not kind to you at all.
Yes, sir.
But this is very simple. If you correlate, this is very simple question.
Yes, sir. Sir, the single atrium.
Okay. I don't say single atrium. I say large ASD is present. I'll help
Large,
you out.
actually, okay, sir. Yes, sir. Both they are seen, but sir, mitral. Okay, okay. Single.
I'll give you the answer.
One second. Yes.
I'll help you out.
Primum type.
No, there is no primum type. This is very classical. Nida has raised her hand already. Wait a minute. Let me try. Nida, let him try first. You always
Sir,
try to
it
beat
looks
him,
like
you know. Nida, you are in Bombay and you always try to beat Yogesh. Just hold on, Nida. Hold on. Let him try.
Sir, it is sinus venous ASD.
No, this is not
Is it
sinus venous ASD. It's
is
a
it
very
ASD?
classical defect. What is the structure?
Where? Sir, as you are asking, in the right ventricle.
This is right ventricle. This is
Ventricle, the right ventricle, left ventricle.
okay. This is
Right atrium.
now the whole game lies in this atrium.
Yes, sir.
I'll
The
try
left
to play
atrium
this
only.
picture, and very rare picture which is not easily seen. Now look at the picture on right hand side.
Doppler. Yeah. So the Chiari network.
No, there's no Chiari network.
Network, no Chiari
No
network.
Chiari
Okay.
network.
Yeah,
Chiari network is
no.
different.
Different. Yeah, it's in the right atrium, not in
You have
left.
always compensated with others' number, you know, Yogesh.
Yeah. Yes, sir.
And both the times you got a difficult questions.
Difficult one. Yes, sir. So it appears some membrane in the left atrium where the flow is getting
Okay,
less. I don't know.
now attempt. You're coming closer, you know, attempt.
Yes, sir.
Okay, Nida, go ahead.
No. Yes, sir.
Yes, sir.
Go ahead.
Sir, can you just repeat your question, sir?
What is the abnormality? Look at this picture carefully. Oh. I thought you raised your hand. That's why I'm asking.
Sir, for ostium primum, it's there, but there is a pericardial effusion.
No, it's tough. It's very tough.
Eustachian valves.
Tricuspid atresia.
No, no tricuspid atresia. Both the valves are contracting. They look at the valve is open, no valves. Something to do with atriums. This is total anomalous pulmonary venous drainage.
Venous condition. Okay, okay.
Look carefully. Look at this slide first over here. This is the hole. So this is right atrium. This is left atrium. Look at this eustachian valve over here. Can you see the eustachian valve?
Yes, sir. Yes.
This is right atrium. This is left atrium. Now all the pulmonic veins, they are draining into left atrium, but instead of draining into left atrium, they formed a chamber and they're draining into right atrium directly. And left atrium is somewhere over here. Go back and I'll show you live clips of all this. Even this is like left atrium is seen over here. All pulmonic veins, they are draining into the right atrium.
Hypovolemic LA.
No hypovolemic LA. This is total anomalous pulmonic venous drainage. Jayanti, you want to say something?
Yes, sir. TA PVC I was about.
TA PVC or PA PVC? Perfect. Even we were lost at one time in this patient, you know. When we did it for the first time, you know, look at the slide when we did it in 2014. Good pickup, Jayanti. Very good pickup. Look at this picture. These pictures are very rarely seen. 1 in 1 lakh subjects you'll find this picture.
Yes, sir. Yes, sir. Difficult.
So here is the left pulmonic vein. All of them, they're draining into the left atrium, right atrium. Anyway, fine, fair enough. It is like, I don't say that this is at your levels. This we have already seen. This we have already seen. No, go to previous picture. Not. I'll leave it this. Okay. So this goes to Yogesh, done. Dr. Majrul Islam, tell me what's the abnormality? Quick, we are just
Yes,
finishing
sir.
around. 3 more questions before we close it down. Abnormal, normal, abnormal. Yogesh, go ahead.
Sorry, AP window. Okay, sir. I don't
No,
know.
this is not AP window. This is
But
pulmonic
connection is
artery. Here's the aorta
Yeah,
in the center. This is left
yeah.
pulmonic artery. This is right pulmonic artery. So this is peripheral pulmonic artery stenosis.
Okay. There
This
was
is present
connection
in
is seen
humans.
during. Yes, sir.
All right, Majroon. Next question is for Nida. Nida, ready?
Yes.
Yes, sir.
Tell me what is this picture is, Nida. You always get pulmonic valves,
Yes,
Nida.
pulmonary
That's
stenosis is almost level.
No. Look carefully.
1 minute, sir.
Like Yogesh is always gets a tough
Sir,
question. You try to-
supravalvular level hai.
Perfect. You got supravalvular
Yes,
pulmonic stenosis.
Pulmonary stenosis.
You've previously got pulmonic stenosis. There's now supravalvular pulmonic stenosis.
Membrane is there, yes, sir.
Yes. Great. Good pickup, Nida.
Thank
Both of you are in Bombay. You must meet each other. You know, both of you are intelligent.
Yes, sir.
No, sir.
No, Yogesh, you are good. I must
Thank you.
appreciate
Thank you.
your knowledge.
No.
And
Thank
Nida
you,
is
sir,
also
but,
good
this
because
is-
she was able to beat you sometimes. You
She'll be always there.
know?
Repeat.
All right. Sai Prashad and nobody else is there. Okay, let me stop over here because this will keep on going for a long time. So good. We had a really good, I'll say like program today, and we enjoyed thoroughly. And we saw a couple of very good, interesting images, and I'm sure you too must have enjoyed today. And hopefully by next week,
Yes,
we'll
sir.
have a certificate distribution ceremony. And with this few words, let me just stop.